The PowerPoint. Yeah. Okay. So it's very so actually I made this for the RNs because they usually do the progress notes, but then before too, the LVNs were the ones that did admissions. So that's why some of you LVNs are here as well. So I wanted to talk about progress notes because I've been noticing some progress notes, not a whole lot, um, are lacking in the information that I seek for my Medicare, thing. Um, so just so we're compliant, and then it's not your fault that you did. You probably were not. We didn't do enough teachings, and then we threw you into the admission process. So you just did what you could in the limited knowledge that you had. So, but now we're gonna have to change that, and we're gonna have um, teachings for you. So, admission progress notes. A good patient care begins with clear and informative admission notes. Um, since we are the first, nurses are often the first medical professionals that the patients see upon arrival at healthcare facilities. So, they have an important job. They conduct the initial assessment and fill out the nursing admission note. This gives a vital snapshot of the patient's health, and that's why nurses should write accurate and detailed admission notes. They help ensure patient safety, continuity of care, and enable clinicians to create an effective treatment plan. Nurses' notes should be accurate. Admission notes should be accurate as they convey key information to the medical team, such as allergies, past medical history. Um, Inaccurate admission notes can lead to errors, treatment delays, or miscommunication. So I did like a how to write admission notes step by step guide. So let's look at how to write an effective nursing initial assessment note. There are four clear steps. Step one, you gather information. Begin by reviewing patients' health records, for instance, hand-off reports, triage notes, and transfer documentation. Next, verify patient's identity and ask follow-up questions about their health condition to confirm details if they are able to communicate. Review the patient's previous charts or medication records if applicable. Step two, conduct an admission assessment. Each facility has specific guidelines for conducting admission assessment. These guidelines often include head to toe physical examination, physiological status assessment, activities of daily living evaluation, and pain and psychosocial needs screening. So, step three, document objectively. When writing nursing admission notes, use clear, objective language. Avoid making assumptions about patient's condition and use only approved abbreviation. You can use phrases like patient states, this and that. And then step four, double check before signing. Well, we don't really need to sign here, but because when you do a progress note, it's you already own that note, right? It will have your name on it. Yeah. So before you complete and sign, double check these important details: patient's personal information, medication and allergy information, any abnormal findings. Lastly, make sure that you have completed all required fields. Okay, so how do you it's like there's a header, and then there's the body of the thing, and then the how you end your progress note. So the header and mission details uh, usually contains a resident name, date of birth, date and time of admission, admitted from hospital, admitted from home, admitted from assisted living, and then the admitting diagnosis, a primary reason, example, post-stroke rehab, are they in for IV antibiotic therapy, Code status, advanced directive. Are they full code DNR? Do they have a, that's not necessary, the DPOA, that's not. It's all usually in the face sheet. So, and then subjective and the chief complaint. So, subjective meaning coming from the resident, right? Resident's stated goal or chief complaint. Example, why they here? So sometimes they say, I just want to get my strength back so I can go home. Usually, and that's usually what we have for rehab. History of present illness, a brief summary of acute hospital stay or events leading to the SNF placement. So the objective, that was subjective, what you heard from the resident. Objective and physical assessment consists of vitals, heart rate, blood pressure, respiration rate, SpO2, pain from 0 to 10. Then there's the general or slash neuro, is that resident alert oriented, or do they have a baseline cognitive impairment? Then you go to respiratory, cardiac, do they have clear breath sounds, regular rate and rhythm? Then you go to skin integrity. So we're just talking about head to toe, right? um, is skin intact, or are did or describe pressure injuries or wounds in stage, size, and location. And then functional baseline. This is usually related to transfers, like transfer assist level, bed mobility, gait status upon arrival. And then we do this assessment and skilled need. So there's the clinical summary. Resident admitted stable or unstable for post-acute skilled care. Are they Med A? Or what are the pair? Specific skilled need, example, daily physical therapy, skilled nursing observation, or just the IV management. And then the last part is the plan of care, the therapy orders, PT, OTST evaluations ordered and pending, medication reconciliation complete, check for discrepancies with hospital discharge order, monitoring vital signs, blood glucose checks, wound care schedule, and then lastly, follow up, notify attending physician of admission, and the family update is provided. Okay, so I talked about the header, the body, and then the last, right? So when you're doing that, you ensure you follow institutional and national admission note guidelines. This includes using only approved abbreviation, completing all required fields, and documenting within the specified time. You must write your nursing note promptly. If you delay writing, there's a greater risk of making a mistake or recording key details inaccurately. This could have ramifications later on for the patient's care. If you want to improve your note writing, peer reviews, or documentations, audits can be helpful. These can help you improve your skills and give you constructive feedback. All right, so there are types of admission notes that you can do. First, there are people who like to do the narrative, right? So there are advantages to using narrative. Narrative is more a flexible style and allows longer, more detailed explanation. There's one drawback. The drawback is this can lead to more inaccuracy or inconsistency. Then I also noticed that some nurses use the checklist format, which is also good. Checklist format is more structured, efficient, and minimizes errors. However, it does not allow for longer, more complex details. And then there's the problem orientated. There are two formats for this. John talked about this. This is SOAP, the subjective, objective assessment and plan, and the DAR, which is a data, action, and response. So good nursing notes does not necessarily have to take you tons of time. Here are some strategies to help you write a good note faster. Use templates and shortcuts. Usually you have like your documents there, or you can just write your template and then you tweak it, just change the name, to suit your resident. Tweak it so that, then prepare during handoff. What does that mean? So we were having like a conversation earlier this morning, because usually before, Cheryl used to bring the whole thing before the resident came, right? She would bring the HMPs from the hospital, the DC orders and stuff like that. So you already have a good picture of how the resident is going to be. You already know the diagnosis, the the drug orders and everything. Now I think it's you, right? Right. And you're good. And so here's the disconnect happens during the weekends when you're not here. So
I feel like she said everybody's good but me.
you're good, John.
Okay,
What
I'm
the heck?
kidding.
So that's what Evan was complaining about, because when you're not there and those things don't get emailed to the skilled nursing, they don't have a clear picture of the resident. Yeah, they don't. Careport or eSIN or whatever. Well, you don't work every day, sweetie, so it's not your fault. So and and have them emailed to. Right. Right. Okay. Right, right. Yeah. No, no, because some of them, like, you can check three already. Like, you know what I mean? Like, they come in like sets. Yeah. Okay. So use templates, prepare during handoff, this and audit your own notes. By being self aware and reviewing your note taking, you will improve. Review your admission note to ensure you have not missed any key data regarding ADLs, pain, or potential risk. For use technology, you already are using technology, right? But number five, share your knowledge within the unit. Within your team, you can exchange effective nursing admission note examples. You can also ensure that you attend any documentation workshops like this, or training sessions that are offered. Yeah. Yeah. So before we used to have like a little guide as to what to ask them. What we do have
I
that?
think it's called S bar.
Yeah. Are we still using that? Yeah. He created. Go good. That's good. I like Evan. All right. So this one, I just tried to include this because this is what we really need. I mean, we took this up in college. So a perfect nurse is a combination of knowledge, skills, and attitude. The knowledge and skills you learn from school. Knowledge is the think. It's anatomy, physiology, pharmacology, disease process, evidence-based practice. The skills are the skills that you do every day. Clinical procedures, starting IV lines, taking vital signs, listening to heart and lung sounds, communication, using electronic records, relaying critical updates, critical thinking, rapidly prioritizing care during emergency situations. And then for me, attitude is very important. It's the one that you don't learn in school. It's the one that you have in your heart or as a person. Empathy and compassion, accountability, collaboration, using the input of other healthcare team members, and continuous learning. So that's it. That's my presentation. So, did you learn something useful? We're able to.
Does everybody get that in terms of admission goes? What we talked about today, and I know elections cover a whole great deal there since we're doing admission. Um, JR actually wrote a whole great like book on admission. He showed like, say, oh, take a look at my admission to see if it's right. And we opened it up, and it was literally like a whole.
It was a combination of narrative and the checklist.
So we had an example today where we had a discussion. If you have a patient that's coming in, COPD exacerbation, you brought him in, it's 91-year-old that's coming from the hospital. This is how you would state it. This is how I would do it in terms of admitted patient from, scripts, 91-year-old and COPD has this comorbidities or whatever. His ANO times 4. You did your lungs and your assessment. Um, you mentioned skin. You mentioned maybe orientation. You mentioned ability, mobility. Um, you also mentioned what else did we talk about in terms of just the basic stuff that we would add on there?
Yeah, hand grips, perla, auscultate bowel sounds.
Yeah. Call
Yeah.
the MD. If you're an LVN at the very end of that, or somewhere in between that, the beginning of the end, you're going to say that you collaborate with an RN for skin assessment or whatever
Yeah.
with your admission.
Yeah.
But I mean, it should be clear, concise. I mean, but at the same time, you want the knock shift or the next shift to kind of read through your note and have a good idea that this patient's ANO times 4 with COPD and their head of bed has to be this, and they need nebulizer every 4 hours.
Yep.
Because these are the people that's going to go back readmission. Readmission rate has to be lower. And how do we do that? We have to monitor every shift for a lot of our patients. And we're doing a good job with readmission to the hospital, but I think to get better, we need better communication. And some of you guys are using shift to shift, but we need more people to start using that because we look at it. I mean, at least I look at it quite a bit when I'm in the desk, but I'm sure some of your coworkers who's working on the floor passing meds the next shift, they're also using that. So we need to be using that instead of writing it on your piece of paper or whatever on your census. Write it on the shift to shift. I know it takes a little bit, more time, but it's just very helpful in terms of communication skills.
So I was talking to John earlier, and maybe I should start talking about progress notes for between shifts. Not and the discharge as well. So progress note for long-term care and what CMS is looking for long-term care. And then and
I love that.
and then progress notes for rehab patients too.
So you're gonna do this more often?
Oh my God.
Come on. This is great.
sure you add that patient was given an orientation to the room and the
Yes,
unit,
yeah, yes, yeah.
especially with the call line. Okay. Um, and
Yes.
then the other thing I would mention is, so the nurse who wrote the admissions note should review his or her own note, but please, if you're working on the floor and you see that, you know that the person came in for CHF exacerbation, say,
Mhm.
okay, because you see the ICD-10 codes and but the admissions note says this patient is here for wound management and there's no wound at all. Please bring that up. Nobody's going to blame anybody. Like it may have gotten charted in the wrong patient or whatever. What I don't want to see is so they, admission RN or whatever, wrote down CHF. So don't just assume, or wound care. So don't assume that's what it is and then cut and paste or copy
Yeah,
and paste that into
that's
your
the thing.
progress note. I've seen that happen. I'm like, oh my gosh. Okay. So bring that up to like the resource nurse or John or my attention or Alexis's attention. Get it corrected because we can always go back and make a corrected note. All right.
Correct.
So
Correct.
don't assume that everything that's on the admissions note is correct. Usually they are, but like kind of review each other's work.
Sometimes,
That's what the teamwork is about, right?
sometimes, like for Charles Knox, for example, we have to do a whole new note for him because he's a new admit. Sometimes the diagnosis from the first admission is not the same as from the second. For him, it's the same, but this is just an example. And then, so the admitting nurse just copies the one from the previous one. So you're perpetuating, like, because the other ship will just copy paste as well. So you're perpetuating a mistake every shift. Like, oh my god! And it's not until the next, maybe that was a weekend, and then Monday you discover, oh my god, this is all wrong. So
And then I just need to add another thing. Like for the orders, like the standing orders that JHC always have, if any floor nurses sees that something is missing, GGs, vital signs, diet orders, I think we are all licensed that we can just add the order instead of like waiting for the next day when we have a resource nurse you know, um, to have them add the order because
Right. Missing.
yeah,
If you're
because
working on the floor.
there were times that GG admissions are missing or like there was an order that is wrong. Instead of correcting it, they would wait until the next day or 2 days before it gets fixed.
yeah.
So
So I know you went over all of the things that you want covered because all of that is already on the assessment.
I
And
know.
it's a long assessment. It's not something like it's like
So here's the thing about the assessment.
every single one that you mentioned.
The nurse doesn't, the admitting nurse doesn't open the assessment, John.
No, I get it.
They
I mean,
see the progress notes, that's what they go off on. The one that's following you the next shift, they look at the progress notes. They don't open an
Yeah.
assessment. They don't really have the time.
yeah.
I feel like the progress note should be like, you don't have to include literally every single piece of information, but just like whatever's pertinent to
Right,
the next person
right.
who's coming in.
Right, and the important thing is the continuity of care. It doesn't have to be like, you really need to use your critical thinking skills, John. It has to come from what their initial primary diagnosis is and their comorbidities.
Okay, so if you're admitting a patient who is a COPD patient,
Right.
we say this 91-year-old female is coming from the hospital.
With acute
family
respiratory
came in,
failure.
acute respiratory failure. She's on oxygen.
Right.
Continues 2 liters. She's not having
Obviously.
shortness of breath. Her lungs are clear. It's kind of tight or whatever.
Yes,
She's
yes.
taking this treatment. These are the skin. She's able to ambulate. She's kind of confused, right?
Right,
ANO,
right.
whatever. And then this is her vitals. Would that be good for you?
Yes,